Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week sessions again. So today we are going to do cardiology role play. So we finished cardiology theory session, and today we are going to go for the role play on the topics that we have discussed. Okay, so the theory sessions are like that. So how we do is we do a couple of theory sessions on a particular subject, and then we do a role play based on some of the important questions for your exam. Sometimes we add new questions in our role play class to make it more interesting, and also so that you can understand some of the other questions that's important for your exam. But we try to do role play on most of the discussed questions so that you know how to do it. But if something we miss in our theory session and we think that no, like one of the cases is important for your exam, we add that in our role play session as well. Okay, so we did not discuss the CVS risk assessment in our cardiology session. We will discuss that today, maybe after the break. But let's start with some role play today and see how you're doing. I hope you guys are understanding how to do role plays at the moment, because we have been doing a couple of role play sessions. So you had a psychiatry role play class, and then Dr. Cynthia has taken a random role play session with you. And then tonight will be your third role play session. Now, again, all of you, or you can say most of you, are beginners in here. So there is no judgment on how you are doing it. As long as you are coming and you are brave enough to do a role play with us, we really appreciate that. And you only learn by mistake. So you can do as many mistakes as you want, because this platform is for you to learn. You are not perfect. That's why you are here. If you are perfect, if you knew everything, you would not join a class for AMC clinical preparation. And I think like most of the people are in the same way, right? Some few might be in the middle of their preparation. They might know a little bit better than you, but when you start your preparation, you will be the same. So don't worry, do some role play, and we will show you that what you can change so that you can do it better. Okay, so let's start. So let's see if anyone interested to do the first role play. M, what's your full name? Your name is showing as M only.
Yes, doctor. I am Dr. Main.
Is it Main?
Main.
Okay. All right, Dr. May. So let's try a role play today. I'll just give you a case, and we'll be doing it like 2-minute reading time and then 7-minute 30-second for the case. But in your exam, you will get 8 minutes. Okay?
Yes, sir. Thank you.
All right. Let's give you a case. Okay, so this is your case. Your 2-minute time just started.
Yes.
Okay, so this is Sarah. You can start.
Good morning, Sarah. I'm Dr. Min, one of the doctor here. So what brings you here today?
I don't know, Doc. It's just the nurse wanted me to see you.
Okay. So I saw that you have been coming here for the blood donation, right?
Yes.
Okay. So at that time, we checked the blood pressure for you. We saw that there is an increased blood pressure in you. Your blood pressure is high. So I would like to discuss about the short conversation. Then I will quickly examine you. Is that okay for you?
Yeah.
Okay. How long have do you notice about, do you usually check your blood pressure regularly?
No, I've never actually checked my blood pressure before. So
Mhm.
I'm just surprised that it's been high.
So for that matter, we check for the blood pressure on the three reading. At that time, we saw that your blood pressure is high. So let me ask the same question for you. Is that okay for you, Sarah?
Yeah, sure.
Okay. So at first, do you have any out of breath or shortness of breath?
No,
Okay. Do you notice from any dizziness,
no, doctor.
any chest pain?
No,
How about reason of the heartbeat?
no,
Okay. Any vision problem?
no,
Okay. Any reduced urine output during this day?
no,
Okay. Do you notice any pain on your leg when walking? While walking?
no, no,
So do you have any known medical problem before?
no.
Okay. Are you aware of your body weight?
No, I think I'm just 75 kilo.
Okay. Any history of diabetes, mellitus, or raised sugar level?
No,
Okay. So do you notice any recent change in weather preference?
no,
Okay. Do you notice any neck swelling in your neck?
no.
Okay. Let me ask the same private and sensitive question for you. Is that okay for you?
Sure.
Okay. How's your period?
It's been regular.
Is regular. When was your last menstrual period?
3 weeks ago.
3 weeks ago. Are you sexually active?
Yeah.
Okay. So are you on contraception?
Yeah, I'm on oral contraceptive pill.
Okay. So how have you been taking oral contraceptive pill?
I've been taking it for the last 6 months, I think.
Like 6 months? Okay. So any history of pregnancy before?
No,
Okay. So do you usually check your fat level before?
no,
Okay. So any family member who has been diagnosed with the raised blood pressure or hypertension?
no.
Okay. Any family member with the heart disease or stroke problem before?
My father has a heart problem.
Heart problem. So I'm really sorry to hear about it. How is he now?
He's doing good now. Thank you.
Okay. So is there any family member who has the sudden death before?
Not really. Everyone died naturally.
Okay. So apart from that oral contraceptive pill, is there any other medication are you currently taking?
No,
No. What do you do for a living?
I'm a student.
You student. I would like to know that today our conversation is private and confidential. You can open up to me friendly, Sarah. Is there any stressful condition during this day?
No, I've been normal. I don't have any stress. I don't feel depressed. So yeah, mentally I'm okay.
Thank you, Sarah. Do you smoke?
No,
Okay. Do you drink alcohol?
very occasionally, just during the weekend.
Weekend, by any chance, any binge drinking of alcohol?
No,
No. Okay, thank you, Sarah. Is there any problem with the financial status?
no.
No. Okay, let me examine you, Sarah. Okay, Sarah. Thank you, Sarah. So I would like to explain about your raised blood pressure. Is that okay for you?
Sure.
Okay, sir. So at first, I would like to know that we found that your blood pressure is raised, and we don't see any significant causes for that raised pressure during our conversation and during examination. We found that only there is a possible cause of oral contraceptive pill you are taking at this moment. So you suffer from that raised blood pressure. Are you with me so far?
Yeah, so you think that the pill is causing this high blood pressure?
This is the one of the possible causes. Another thing is that there are many reasons that has the causes of the raised blood pressure. We usually call the secondary hypertension. They are due to occurring related to the thyroid problem, which is present in neck gland, present in the front of the neck. Another thing is it may be related to the gland problem like pheochromocytoma, which is the present in our tummy. It produces the hormone which causes the raised blood pressure. Other condition, it may be related to the familial disease, and other condition, it may be related to the associated with the diabetes mellitus or rate sugar level. But currently, we don't see significant medical cases in you, so we have to do the regular monitoring as you. Is that okay for you?
Yeah, sure.
Okay. At first, I want you to know that we will discuss with the women specialist gynecologist and for the changing of the Medicaid or contraceptive pill because this is the one of the possible reason we found that for your reason of the blood pressure. During this time, we will be monitoring your blood pressure. Okay.
Yeah.
Okay, another thing is that that hormonal pill can causes the hormonal changes and the salt and water retention that can occur, which can lead to the raised blood pressure or hypertension. So we need to stop the hormonal contraception fast. At the time, I would like you to avoid to use the condom monitor for the at least 3 months. Are you with me so far?
Yeah.
Okay. If the blood pressure is still higher despite avoiding contraception, we will do the further investigation for you. Okay, Sarah?
Yeah. Thank you, doctor. Your time is up.
Thank you,
Okay.
Sarah.
Very good, Dr. May. It's really good how you have done it. You are doing really, really good. So I feel like maybe if it is the online exam, try to change, like try to see because sometimes the sound is not coming really like in a clear way from your end. So check the microphone, especially before you go for your exam. See that if that is doing well. Otherwise, I would say that you know what you're doing. Your approach is very nice. The time when you said, like when we said, my father had a heart condition, and you asked that, how is he doing now? I'm so sorry to know that. This matters a lot in the exam because it means that you care for the patient and then you get a good mark in your approach. So people forget about these small things when they really do it. Okay, so you are right that this case is about oral contraceptive pill-induced hypertension, but let's discuss hypertension in detail and then you will also understand if there is something else that you can add here. But I think like you have done everything right. So you asked about all the secondary causes of hypertension. You try to rule out any complications of hypertension. So that's the main part. Okay, so let's discuss the case from our note, and then I will come back and we'll give you some more feedback to you. Okay, thank you.
Thank you.
Hypertension, important for exam. So The case is hypertension. You need to find out if it is a primary hypertension or it is a secondary hypertension. So secondary hypertension, only 5 to 10% cases, but there are lots of cause of it. So thyroid, that you should rule out. Renal artery stenosis is important to rule out. We should also rule out coarctation of aorta, but you can't actually ask any history for it. So if you see the mnemonic, that's called trackpads. So trackpad is the mnemonic of secondary causes of hypertension. So thyroid, renal artery stenosis, aorta, which is coarctation of aorta, C for Cushing disease, K for kidney problems, especially chronic kidney disease, polycystic kidney disease. So all the kidney disease will come over here. P for pheochromocytoma. So there is history or questions you can ask here. A for aldosteronism or Conn's syndrome. And then D for drugs, S for sleep apnea, which is obstructive sleep apnea, and then stress. So these are the main secondary causes that we should rule out in our history. So first of all, you introduce with the patient. The HOPC was high blood pressure. So you will explain to the patient, hi Jenny, we have found high blood pressure on multiple readings. Has this ever happened before? That means, do you know that you have high blood pressure? No, doctor. Well, let me explain, or you can say, let me ask you a few questions to find out if there is any cause behind it, and then we'll talk further about what we can do about it. So, do you have any symptoms like chest pain, shortness of breath, any racing of your heart? So, first we try to find out if the patient already got any complications from uncontrolled hypertension. Any problem with your vision, any leg pain while walking, okay? Then we go for secondary causes. So for hyperthyroidism, any change in your weather preference, any change in your bowel habit or body weight. Have you noticed any lump on your neck? For kidney condition, how is your water works? Any reduction of your urine output? Any headache, frequent leg cramps? Any swelling in the body? So CKD patients sometimes can get frequent leg cramps. They can get swelling or edema. Any lump or bump on your tummy, that's for PCKD. Any family history of kidney condition. For Cushing syndrome, we ask have you noticed any change in your face? Like we really want to find out if the patient having a moon faces. Or have you got increased acne or hair growth on your face? Any muscle weakness or easy bruising. So that's usually only 1 or 2 symptoms of each condition is enough. For pheochromocytoma, do you get episodes of headache, flushing of the face, or excessive sweating? For OSA, do you feel fatigued or tired in the morning even after having a good night's sleep? And most importantly, anyone complained that you snore while you sleep? Then give a confidentiality statement, find out if there is any stress at home or work. And if it is a female patient, we ask about the 5P, which means 5P includes period, pill, partner, pregnancy. And previously we used to say pap smear, but now it's cervical screening test. So we ask the patient, how's your period? Is it regular, irregular? When was your last menstrual period? Are you sexually active? If yes, are you on any contraceptive? In this case, the positive finding will be patient is on oral contraceptive pill. So you need to ask a little bit questions about it. So how long you are on it? And is there do you take it regularly as prescribed? Any complications or side effect from them? And ask about pregnancy. So have you ever been pregnant before? And are you regular with your cervical screening test? For a 22-year-old female, we don't need to ask it because CST is mainly from 25-year-old and then above. So for 22-year-old, don't bother with CST. And then lastly, smoking, alcohol, past medical history, family history of heart condition, and ask about any medication patient is on other than OCP. So pretty straightforward history, and then your explanation should be like this. So, hi Jenny, thank you so much, Jenny, for all the information that you have given. From history and physical examination, because we have found your blood pressure is high in 3 settings, most likely you have got a condition called hypertension, which is increased blood pressure in your blood pipes or increased pressure in your blood vessels or pipes. But please don't get scared. It is not an uncommon condition. Most of the time, we can't find out any underlying cause. But in your case, I suspect that it could be due to the oral contraceptive pill that you're taking. But it could be due to other causes as well. So then give some DD and say why it is unlikely. So to rule out these causes, I would like to organize few blood tests. So you can definitely order some blood tests, including full blood count, liver kidney functions, thyroid function, and blood sugar level, and also find out the lipid profile. If everything comes normal, then we can be sure that it is just the oral contraceptive pill that's causing the high blood pressure. Jenny, if we don't treat it or if we can't control the blood pressure, it can cause serious complication which can affect your heart, brain, kidney, as well as your eye vision. But you're too young and you do not have any other risk factors, so we can definitely manage your blood pressure and you should be fine. That's why I would advise you to stop the oral contraceptive pill and please make another appointment so that we can discuss further contraceptive options. In between that, if you are going for sexual intercourse, please make sure that you use condoms. It's also very important to maintain a healthy lifestyle. So talk about lifestyle modification, which will be try to adopt a healthy, balanced diet. Try to do exercise at least 30 minutes a day every week, 30 minutes a day, 5 days a week, and then maintain an ideal body weight. Okay, so mainly lifestyle modification is ideal body weight, exercise, healthy balanced diet. So that's 3 is the main part. And then say that I will give you some reading materials about it. I will have a review after the blood tests are back. Do you have any questions? Okay, so that's usually should be the case. Very easy case. If you know what you're doing, you will pass the case without any problem. And Dr. May, you have done everything right. So I can't say that anything you have missed. So it was perfect.
Thank you, doctor.
No worries. Thank you. Do you guys have any questions? You can understand how to do a role play?
Yes.
Great. Okay, let's do another role play. So I can see Dr. Vijaya, you wanted to do the role play. So do you want to do now?
Yes. Can I?
Great. Okay. I'll give you the case just in a minute. Okay, so this is your case, your 2-minute time just started. All right, so this is your patient, David. You can start.
Hello, David. This is Dr. Vidya, one of the GP here working here. So, how are you?
I'm all right, doctor. Thank you.
Yeah, how can I help you, David?
I'm just like quite anxious because I've been having this fall and I just don't know why this is happening with me. I feel like I'm just going to fall most of the time. So that's why I'm here.
Okay, don't worry. You have come to the hospital. You are in a safe hand now. So, we will address your problem and we will manage accordingly. Okay, it is all right with you?
Yeah, sure.
Okay, ja, now just tell me. So I can see from your notes, so you're having recurrent falls. Is that correct?
Yeah.
Yeah, just tell me more about, so each time you fall, so when did you have this happen last?
The last one was 2 days ago, and I was just like coming out of my washroom, and I just like I was sitting on my sitting over there for a couple of minutes, and then suddenly when I stand, I, I just felt dizzy and I had a fall. And
Or,
most of the others, it just happens when I get up in the morning.
all right, I understood. So did you knock your head anywhere? Did you got any injuries?
No,
All right, so all three times, so it's just happening. So when you change your position, is that correct?
yeah, mostly.
So whenever it has happened while you go into the bathroom, while you are peeing, it ever happened?
No,
All right. So are you lost consciousness during a swallow fall?
no,
So you're aware that so before that, are you get dizzy or any headache, any blurring visions before
I
you
just
fall?
get dizzy, that's it.
All right. So uh, at the moment, do you have any pain anywhere else or any chest pain, any funny racing rhythm?
No,
All right. So, do you have any, do you had, or recently or at the moment have any fever or any cough or anything?
no,
Any rashes anywhere else in your body?
no,
Okay. Any lumps and bumps?
no.
Mm. All right. Do you have any that, do you feel anywhere else, so tingling, numbness, your legs and hands?
No,
All right. Do you feel your back of the leg is heavy and tender?
no,
Uh, do you have headache or anything at the moment?
no.
All right. Um, so, do you have any past medical history like a high blood pressure or diabetes?
I have high blood pressure, but no diabetes.
No. All right. So also I can see that you're suffering from knee problem and like sleeping problem. Is that correct?
Yeah.
Um, all right. So do you went underwent any surgery recently?
No,
So are you taking any blood thinner medications except these other medications?
no.
All right. So do you go regularly to visit your physician?
Sorry again?
Are you going regularly to visit your physician?
No,
Okay. Um, do you have any sleep problem?
yeah, I have a sleep issue, but I just need to take that medication sometimes.
All right. During nighttime, you more frequently you have to go to the washroom.
No,
So, do you have any problem in pee and poo?
no,
Either any problem with your water?
no,
any burning sensation, any discoloration, any of that?
No.
All right. Do you have any support at home?
Yeah. I have my wife with me.
All right. During nighttime, to the washroom. So, do you have any adequate light or anything?
Yeah, I have adequate light in my room.
All right. If there's any the carpet removed, disconnected, or any floor deformities,
No,
is
everything
there?
is good.
All right. Okay. Yeah, thank you. All right, David. So far you're with me, right?
Yep.
David, according to your examination, so I think that the condition you have, that postural hypertension, are you aware that what is that?
No, doctor.
It's a condition, the blood pressure, so from your, while you're changing the position, it's suddenly dropping. So because of the low blood pressure while you're changing the position, so your brain get low blood pressure. So because with the blood with carries oxygen, so it's inadequate of oxygen, inadequate of blood pressure, so you lost consciousness, you having the recurrent faults. So this is the cause, because I couldn't find any other cause, and so also and other things. So I was thinking you are taking a lot of medications, so to exclude that the polypharmacy might cause your problems.
Time up.
So,
Thank you, doctor. Okay.
um,
All right. No, that's fine. There is nothing wrong. You have tried, and that's the main thing. So I'm sure you will do more and more better. This is hard. These are hard cases, but these are very, very important for exam. So you have done well, but again, the main thing is that when you get that 2-minute time, Dr. Vijaya, you need to remember those differential diagnoses, because if you don't, throughout your history, you will keep on remembering them. You will waste time and you will ask questions which is irrelevant. So that's what happens if you can't remember the DDs. So what are the DDs of recurrent fall?
The postural hypertension, polypharmacy, anemia, and that the drugs related is taking night tamoxifams. It might cause any light sources, any carpet disconnections or anything, and vasovagal while passing the elderly patient.
Yeah, so
Yeah.
basically CVS cause, CNS cause, that's important to rule out. And then you can rule out the miscellaneous, which is your vasovagal, postural hypertension. Now, when you get postural hypertension positive in your history, you need to find out what's causing this. So polypharmacy is the #1 cause. So in here, patient is taking medication. It's not like a lot of medication. So Temaz, ibuprofen, paracetamol, and olmesartan. Among them, these two, olmesartan and the Temaz, these two can actually cause fall. So you can find out about these two medications. So how long you're taking the temazepam, and I can see you take 10 milligram. Is there any chance you are increasing the dose recently? Patient will say no. Then how about your olmesartan? This is your blood pressure medication. What's the dose of this medication you are taking? Patient will say, I'm taking, let's say, 10 milligram or 20 milligram twice a day. So now normally twice a day dosing is not common for blood pressure medication. So ask the patient that, well, has it been increased in dose recently? you'll find out that previously patient was once a day dose. Now, just for the last 6 months, maybe, so it will correlate with the duration. So for the last 6 months or last 6 months ago, it has been increased to twice a day. So that's the time you'll find out that, well, increasing a antihypertensive medication sometimes can be the only cause of postural drop. Okay, so any medication which can drop the volume of the body, if the patient is taking more than required, then definitely that can be the cause. So this case was olmesartan induced postural hypotension. Okay, so that's important to find out always. And what else can cause postural hypotension? Any recent vomiting, diarrhea. If the patient is bleeding from somewhere, then if the patient was diabetic, we would rule out diabetic autoneuropathy as well. So those would come if the patient had a diabetes. So that's postural hypotension. Then you ask anemia, one of the DD. You need to also rule out, like, as you say, that you need to rule out the local causes. So osteoarthritis of the knee. If the patient is having loose carpets, poor lighting in the home, if the patient is drinking heavily at night, they can easily have a fall. So all of these will come in your differential diagnosis one by one. And most importantly, with the fall case, try to divide what happens before fall, during fall, after fall. So those format that we have taught you in the class, there is a reason for it, because if you do follow those format, you will not actually miss any important things. Okay. And in this case, your diagnosis will be postural hypertension, and then you will give the reason as olmesartan increased dose causing it. You'll explain what is postural hypertension, as we discussed in the class, that postural hypertension is drop of blood pressure in relationship to change of position. Most importantly, when you change your position from lying to sitting or sitting to standing. Sometimes in elderly patients, their body needs a little bit more time than a normal, healthy young patient to push their blood from periphery to the brain. So if a patient's already elderly and they are taking volume depleting medications such as olmesartan with the increased dose, they are already having a bit of dehydration. On the top of that, when they are elderly, their muscle tone is not really high. So for the blood to go straight from the lower extremity to the brain, it will take a little bit longer time than a normal healthy patient or a young patient. So that's why this recurrent fall due to postural hypertension, these are more common in elderly patient than a young patient. Okay, so you can always explain in this way, as I said, but give some of the differential diagnosis in here and give the reason, which is the increased dose of olmesartan. Okay. Any question, guys? So we are not discussing the postural hypertension again because we discussed that. Make sure you again revise the differential diagnosis and history, and you'll be fine.
Okay.
Okay. Thank you, Dr. Vijaya.
Thank you, sir.
And Dr. Abdul, yes, you would be able to do a role play, but there was Dr. Weni. So Dr. Weni, do you want to do the role play now?
Yes, please.
Very
Yes,
good.
doctor.
Okay, let me give you the case, just a second. Okay, let's do the case which is like a very, very common case for the exam. So your 2-minute time is started.
I see the ECG or do I wait for the next?
Let's wait here.
Okay.
All right, Dr. Veni, so this is John. You can start.
Okay. Hi, John. Good morning. I'm Dr. Wenny. How may I help you today?
So I just don't know. I'm having this chest pain, and I can't even breathe because it just hurt a lot. It feels like someone is just pressing on my heart.
I'm so sorry to hear that, but before that, I'll shift you to the resuscitation room to make sure your vital signs is stable. You mentioned that you're in pain. Do you need any painkiller for now?
Yes, please.
Okay. Do you have any allergies?
No.
I'll ask the nurses to give you some painkiller. So you mentioned that you has a chest pain. Can you tell me more about the chest pain?
Yeah, I was just like jogging in the morning, and then suddenly I felt a pressure on my chest, and then it just like getting worse and worse. So that's why I just came in here.
Okay, okay. I'm so sorry to hear that. You mentioned that you have been jogging this morning. So how many hours ago was that?
It just started 30 minutes ago.
Okay, is this the first time you're having this chest pain?
Yes,
Okay. If were to give you a scale of 1 to 10, 1 is not painful, 10 is the most painful thing that you ever had, how much would you give for your pain?
7/10,
Okay. Is it on and off or is it continuous?
continuous.
Okay. Is it worsening?
It is getting worse.
Okay. Does the pain moves to any other part of your body?
I feel it in my left arm.
Okay. Okay. So is there anything you do that will cause the pain to be worse?
No,
Okay. Anything you do that will makes the pain feel better?
no,
Okay. I'll ask you a few other more questions. Do you have the sensation that your heart is beating very fast?
no.
Do you have any difficulty in breathing?
Yes,
Okay. Do you feel that you are sweating more when you have the chest pain?
I am sweating at the moment. Yeah, it's right.
Okay. Okay. Besides that, may I ask, do you have do you have any swellings in your legs?
No,
How many pillows do you sleep at night?
just one.
Okay. Do you often awakens at night because you can't breathe?
No,
Okay. Other than that, for the past recently 1 to 2 weeks, do you have any fever?
no,
Any cough?
no,
Okay. The pain that you have, is it better when you lie down or when you sit to lean forward?
No.
Okay. May I ask, do you have any dizziness recently?
No, doctor.
Okay. Other than that, do you have any trauma to your chest?
No.
Okay. I would like to ask, do you smoke?
Just very occasionally.
Okay. How many cigarettes do you smoke a day?
Sometimes I don't, and sometimes maybe one or two.
Okay. Since when have you been smoking? How many years ago?
It's been 20 years.
Okay. Do you drink alcohol?
No.
Okay. Do you have any past medical history that I would like to know, particularly hypertension, diabetes?
My GP told me that I had high blood pressure, but I forgot to attend further.
Okay. So are you on any medication? Did your GP start you on any medication?
No, I didn't follow up.
Okay, okay, understand. At that time, did they check for your blood sugar or any the fat in your blood?
No.
Okay. Other than that, may I ask, do you have any family history of particularly any heart attack or any stroke?
Yeah, my father had a stroke.
Okay. How old was he when he had the stroke?
Yeah, he was pretty bad.
Okay, I'm so sorry to hear that. Besides that, do you have any family members who passed away early, around
No.
the age of 20 plus 30?
No.
Okay. Uh, may I know what are you working as?
Sorry, pardon?
May I know what are you working as?
Sorry, couldn't understand.
May I know what's your job? What's your occupation?
Occupation. Yeah, I'm just like a businessman.
Okay. On and off, do you have any discomfort of the chest?
No.
Okay. Uh, please excuse me, I would like to speak to my examiner. Dear examiner, can I have a look at the ECG? Okay. Thank you for your history and thank you for the ECG. Uh, I am so sorry that I have to tell you that what you have is what we call myocardial infarction, particularly over the anterolateral. This is actually a heart attack. It occurs when there is not adequate of supply of the oxygen to the blood vessels and the heart. So, dear examiner, the ECG that I had is actually an ECG that shows sinus rhythm with the heart rate of 80 beats per minute. I can see there is it is sinus rhythm and there is ST elevation over the lead 2, 3, and 4, which is the anterolateral. Otherwise, I don't see any other irregularity in this ECG. So I will manage this patient by first, if I'm in a tertiary hospital, I'll admit the patient. I'll provide the patient with oxygen, give the patient aspirin, as well as give the patient GTN. And I will like to consult my cardiologist in the tertiary center. And meanwhile, if I got a approval, then I will start this patient with thrombolytic for this patient. And this patient would need to be admitted and stabilized and transferred to the tertiary hospital as soon as possible.
You still
Prior
have
to
20
that,
seconds.
Prior to that, I would also like to take blood investigation, full blood count, the cardiac enzyme, and also the troponin for this patient.
I'm not. All right. Dr. Veni, very good. You were doing really, really good. But just when you came to explanation of the ECG and in here you got distracted and like you were too fast. So I know that sometimes you feel like time is going and then you just want to finish. But that's also remember one thing that finishing should be appropriate as well, right? But you are doing really good, and I'm sure you'll be doing much better after the 5 months course. So what we normally say in here, like, it is a brief history from the patient. The history that you have taken was good. There was not much to add in here. So, but just when a patient with chest pain who sound a bit stressed, just reassured that you are here with him. So say that, I understand it must be very scary for you, but now that you're here, we are going to take care of you. So John, would you tell me a little bit more about this chest pain? So when you say something like this, examiner is happy, role player is happy, everyone is happy. So we always advise in acute scenarios, try to reassure the patient from the first. You are not saying anything which is false. You are just saying that you are going to take care of it. Once you do that, then patient will give you the chest pain history. You finish with all the Socrates, and then you rule out most of the important DD. In this case, you don't have a lot of time, right? There is history, ECG explanation, management. So it is a long task to finish. So history should be brief. Just chest pain history, then maybe just respiratory differential diagnosis you can rule out, and then you just go for some of the risk factor of myocardial infarction, so family history, smoking, alcohol, past medical history, and then you finish it, which you have done really well. Then when you came to the ECG, you forgot about the task. So always remember, when you are in the first 2 minutes, don't forget to read the task, because that will give you an idea that what you are supposed to do next after history. So always look at the 3 tasks that, well, I have to take a history, then ECG explanation to examiner, and then management with the patient. So every task, however it is written, you have to do exactly in the same way. If you explain the management with the examiner, there will be no marking over there. Okay, so it's always important to know that what the task is, because you might do everything right, but still they would not be able to mark you if the task was not done appropriately, right? So it's very, very important for the exam to know the task. And then ECG explanation was all right. So in here, 1, 2, 3, 4, 5. So yes, 60 or 80 beat per minute, as you said. Then just follow the ECG format. So rate, rhythm, P wave, QRS complex, then talk about the ST, and then the T. In this case, there is a ST depression from V2, V3, V4, and there is ST depression in lead 1 and AVL. Also very important to note that there is marked T wave inversion in all the chest lead. Okay? So you need to mention that as well, that there is a T wave inversion in here. So this was acute myocardial infarction. So because management is a little bit detailed in here, right? So further management, they did not say immediate management. So when they're asking about further management, you need to at least like have 2 minutes to talk about the management. So first explain what is heart attack or myocardial infarction. Reassure the patient that because you are here within the shortest possible time, we will be able to treat you, and this can be managed effectively. But as we're in a rural hospital and the nearest tertiary hospital is 4 hours away, we don't have any option to transfer you to the hospital. Because in tertiary hospital, the best management for this kind of condition is to take you to a specialized catheter lab where they can actually take that clot, which is blocking your heart blood pipe, and then restore the blood supply. That is the best management. But don't worry, we have alternative options in here. I'm going to first, like, definitely you will say, I'm going to take you to the resuscitation room, which you can even say at the first. So you are with us at the moment. We are going to take some blood for necessary investigation, including a cardiac enzyme. We'll start you with aspirin. So definitely mention about aspirin, morphine, oxygen, nitroglycerin. Monotherapy first, and then this patient needs thrombolytic medication. So you are going to talk to a cardiologist in the tertiary hospital, and then depending on the cardiologist's opinion, most likely you'll be able to go for thrombolytic medication in this patient, given there is no contraindication of that. Okay, so management should include all of them, not just thrombolytic. Monotherapy, you have to say aspirin. If you don't say aspirin, the case cannot be passed. Okay, so it is an easy case, or you can say it is a common case. I never say this is an easy case. It is a common case, but most of the candidates fail this case because it is tricky. All right, and finishing this case is difficult in the exam. So make sure you do this case multiple times with your study buddies, and then find out how much you can say in that given time. Okay.
Dr. Ashan, I would like to ask,
Okay.
for this
Yeah.
case, because they ask for further management, do I need to mention the stop smoking or the lifestyle modification all in this?
No, not at the moment. So definitely you can, if you have time, then you can mention, but it is not the priority in here. The priority is to treat the patient first.
Okay, thank you.
Thank you. Yeah, so Dr. Nisarg, so if there is a management in the task, the management includes diagnosis, investigation, and management, all of them. Vinita, so can we see the task throughout the 8 minutes? Yes, you can. It doesn't disappear. So are you guys getting the hang of it, like how this actually works? Because clinical students, they get the main confusion to understand what is Dr. Arshan saying about role play. All he is talking about is role play. So what is that? So this is actually what is role play, and doing this role play makes you confident to do this case in your exam, to understand what actually this 8 minutes means. So you don't see the watch in your exam, but it's like driving a car multiple times in the same road. When you do that, you don't need to even look at the map. You know, like, where to go. It is the same in your clinical exam. When you do a case multiple times, you know how much you can say without even looking at the watch. Okay, so that is what I can say. Because it is difficult, you might think that how can I know that I'm not running out of time? The main thing is that we all pass the exam exactly in the same way you are going to pass. So if we could know what was 8 minutes, you would also know it. It's just about doing the case, understanding the time, and you'll be fine. In exam, do we have to ask for the ECG? It is ideal to say, so once you finish the history, you should always thank the patient. So thank you so much for all the information, John. I'm going to talk to my examiner and come back to you. So then if ECG is not still shown in your screen, just say, dear examiner, can I please have a look at the ECG? No, Dr. Kamodi. So the first case we have done, it was a secondary hypertension. It was oral contraceptive pill induced hypertension. Okay, very good. We're going to take a 5-minute break now. And after the 5-minute break, we will do the CVS risk assessment. And then I would see if any of you are also willing to do the role play. So we still have a lot of things to do role play with. So make sure you are here after the break is done. But we'll first discuss the CVS risk assessment, and then we go from there. Thank you.
Cardwise.
Sideways, yeah, exactly. And then you use the end of the tip. Wait, no. You do it. How do they do it? Like as if you know you.
All right, everyone, let's start again. Okay, so it just stop sharing, and I'll just share the note of CVS risk assessment. So CVS risk assessment comes in exam, and it's an easy case if you know what to say. It's a better case than a chest pain case. So CVS risk assessment, so all of you know what is CVS risk assessment, that 5-yearly cardiovascular chart that we use. So you are a GP, a middle-aged man come to have a consult after his brother went for coronary bypass 2 weeks ago. He is obese, no other past medical history. You have to take a focus history from him, physical examination finding will be given, and explain what would be the initial management. So when we find out if a patient has got high cardiovascular risk factor, we use this mnemonic ABCDEFS. So A for alcohol, B for blood pressure, body weight, C for high cholesterol, D for diabetes and diet, E for exercise, F for family history of heart condition, S for smoking, stress, and we finish with past medical or surgical history. So pretty straightforward if you know this mnemonic. So this is all that you'll need to ask. So again, ABCDEFS, that's what we ask in here. So what will you say in this case is that, first of all, this patient came for a consultation. So you'll say, "Hi, John, this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. I'm so sorry to know about your brother who had a bypass 2 weeks ago. How is he doing now? Is he all right?" So see that we are showing the empathy to the patient, and this is really, really important. And patient will say, "Yes, doctor, thank you for asking. So can I know what brings you here today?" So patient will say, "I'm just worried about my brother. I just don't want to end up like him. So I want you to tell me what are my risks to get a similar condition like my brother." You will say that it's really good that you came here. I really appreciate that you want to know about it, and definitely I can help you to manage this. But I need to ask you a few questions to find this out. So at the moment, do you have any symptoms of any heart condition such as chest pain, shortness of breath, especially shortness of breath on exertion? That means when you do any exercise, any racing of your heart. So these are most important: chest pain, shortness of breath, racing of the heart. You can also ask a couple of other questions related to cardiovascular system. Do you get blurring of vision, any weakness anywhere in your body? Okay, do you get pain in your lower legs when you walk, to rule out PVD? So just to get an idea that if this patient has high cardiovascular risk symptom. Once you have asked the symptom question, then you go to this ABCDEFS question. So you can ask one by one: do you smoke or drink alcohol? Do you have high blood pressure? Are you aware about your BMI or your body weight? How about any history of high cholesterol? Do you exercise? Do you have a healthy, balanced diet? Any family history of heart condition apart from your brother? Who do you live with at home? Are you a happy family? Is there any stress at your home? Do you do any work? Is there any stress at your work? Any financial issues? Any other past medical or surgical history? So it is just about asking these questions one by one. So then a physical examination card will be given. So in the card, you would be looking for, is there any sign of high cholesterol in that patient, like genital asthma or xanthoma, any corneal arcus? Definitely look at the blood pressure when they give you the vitals. So to make sure the patient is not hypertensive. BMI will be important to check if the patient is obese. And then CVS, respiratory, abdomen, this should be fine. Check if the blood sugar is high, that means patient might be diabetic. And an ECG to make sure patient doesn't have any other baseline ECG problem. We also try to look for that cardiovascular risk chart if that is given in the exam or not. The cardiovascular risk chart looks like this. You all know about this. So sometimes they give the cardiovascular chart and then you need to put all the risk factors on that chart and give a specific risk percentage to the patient. Sometimes they don't give any chart. You just need to talk about the risk factor. So let's say they haven't given any chart in here. So you'll say from the history and examination, I found that you have some risk factors, which is you have a high blood pressure, your body weight is higher than normal, you have diabetes, and your diet contains fatty food rather than healthy balanced food, and you have been smoking for the last 20 years. All this can put you on some risk of having heart-related complication in the future. But please don't worry because we can prevent this by adopting a healthy lifestyle. So I would advise you to cut down your alcohol to the safe drinking limit. Try to maintain ideal body weight. Please avoid smoking. If you give me the consent, I would like to make further appointment to discuss about it. Please take a healthy, balanced diet, which is very important. If you want, I can also send you to a dietitian for a proper dietary plan. Try to do some exercise, at least 30 minutes brisk walking on most of the days of the week. Try to avoid stressful work. I would also like to arrange some investigations, so full blood count, your liver kidney function, ECG if it is not done, blood sugar, and lipid profile to check your cholesterol. Once I get the investigations, I would be able to put your cholesterol, your age, and your blood pressure in a 5-yearly cardiovascular risk chart, and we can find out how much risk you have to get a heart condition in the next 5 years. And then we can manage you accordingly. Okay? And then finish with 4R. So that will be the case in here. It's pretty simple. You just need to talk about what are the risks this patient has got and what they can do to prevent a major stroke or a myocardial infarction in the next 5 years. Okay? There is one case. In another case, which is not quite often coming in the exam anymore because it is difficult for online exam. So they give you everything that you need to put it in this chart, and then they ask you to estimate the cardiovascular risk and give further management to the patient. So everything is same in here. All you need to know is how to place this number on a CVD chart. So in the CVD chart, you see that this is people without diabetes, men and women over here, then a smoker, non-smoker. You have got A's on this side, and on the y-axis, you have got systolic blood pressure, and on the x-axis, you have got cholesterol HDL ratio. Okay? So this is the most important thing. Now find out where we should look. So we have got a middle-aged 57-year-old man, and he's a smoker. So it's a 57-year-old. So this group, smoker, male. So we are mainly looking at this part of the chart, right? So now that we know where we are looking, we need to know what is the systolic blood pressure. So systolic blood pressure is 160. So if we see here, you can see this number 120, 40, 60, right? So normally you need to remember that this chart, this box over here, so this lower box, the highest limit of systolic blood pressure that you can place here is up to 130. It's not 120. Same in here, this box, you can place up to 150. This box up to 170. So our patient has got systolic blood pressure of 160. So definitely this box is the box that we are looking at. If it was 165, it would be still the same box, right? Does it make sense to everyone? Yeah, good. Now, the next thing is x-axis has got cholesterol HDL ratio. So we know it is 8:1 ratio. So 8 is our number. So in here, you can see 4, 5, 6, 7, 8. So if we look over here, so this box, the highest number you can place here is not 4, but it is 4.5. This box, which is marked as 5, the highest number is 5.5, 6.5, 7.5, 8.5. Okay? So now we know our patient has got 8. So 8 means on this box. So if we go up, so this is 160, right? So this red one is what our patient is at the moment. Now we compare this over here. So red means more than 30% risk. And that means it is a high risk patient. Okay? So this is how you can find out that if your patient has got mild, moderate, or severe risk of cardiovascular event in the next 5 years. Okay? So how you can explain this to a patient? So you need to just make it as simple as possible in your exam if it is a task that you need to explain to a patient. So you say that, John, we have got all of the information, your blood pressure, your previous medical history, and your cholesterol level, and we put all of your information in a cardiovascular risk assessment chart. In the chart, it is based on men and women, smoker, non-smoker, diabetes, without diabetes. And then we mainly take account of your top blood pressure and your cholesterol ratio. So when we placed your blood pressure and the cholesterol in this cardiovascular chart, if you can see there are different color in here. So there is red, yellow, green, blue. We have found that your marking puts in red box. And then we look at this red box, which means you have got a high risk, which means more than 30% risk to have a cardiovascular complication in the next 5 years. And that means that the risk of having a stroke or heart attack. I'm so sorry to tell you this, but please don't get scared. It doesn't mean that you are obviously going to get it. Now that we know your risk factor, we can treat you and we can help you to prevent this complication to even happen. Okay, so then you talk about all the lifestyle advice and all of the others. So that's making it as simple as possible for the patient is important. Okay, any question, guys, with this one? Okay, So who wants to do the role play now?
I can try, doctor.
Yes, good. Dr. Abdul, we can do it. Okay, let me give you a case. Just a second. Okay, so this is your case. Your 2-minute time just started.
Okay.
Okay, so this is your patient, Jenny. You can start.
Hi, good evening, Jenny. My name is Abdul Stanigzai, one of the doctor. What brought you in today?
Doctor, I'm just feeling like I can feel my heart is thumping, and it feels like it's just going to come out of my chest.
Sorry to hear that, Jenny. So, can you please tell me a little bit more when does it started?
Just started 2 hours ago when I was just walking on the road.
Is it the first time you're having this palpitation?
No, this is the third time in the last 3 months.
In the last 3 months, okay. And when was the last time before this?
Just a couple of weeks ago.
Is it the same or different?
It's the same.
It's the same, okay. So, do you still have that bracing your heart or that's stopped?
It's still there.
It's still there. Is it getting worse or is the same as it started?
It's the same.
It's the same. Okay. And the palpitation or racing of the heart, is it like tap, 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 and then stop, and then tap, tap, tap again? Is it like this or it's continuously beating faster?
I don't know, doctor.
Oh, okay, okay. Do you feel dizzy?
Yeah, I do.
Mm. Also, do you feel like lightheaded?
No,
Okay. Do you feel any chest pain?
no,
Okay. Any shortness of breath?
no,
No. Okay. Also, any recent travel history?
no,
Okay. Um, um, have you lost your consciousness? Anything like that that happened?
no.
No. Okay. And um, what about your past medical history apart from this palpitation? Any other medical condition that I should know?
No,
No, okay. And or any diabetes, high blood pressure?
no,
No, okay. And any high cholesterol?
no,
Okay. Are you smoking?
No.
Okay. Do you drink?
Just occasional?
Okay. Are you currently taking any medication?
No.
No. Okay. And are you allergic to anything?
No.
Any family history of any heart diseases or things like that?
No.
No, okay. And also, as a last question, do you drink a lot of water? You're not drinking a lot of water?
Just a 2-liter water every day.
Okay. So when this palpitation or racing your heart started, so what were you doing? Sorry?
Just like walking.
Just walking, and that's started all of a sudden.
Yeah.
Okay, okay, okay. Okay, Jenny. So excuse me for a moment. So I want to talk with my examiner and then I will get back to you, okay?
Okay.
Okay, sorry. Do I need to explain this to the patient or to the examiner? Yeah, okay. Examiner, okay. Okay, dear examiner, this 12 lead ECG and I can't see any P wave, so it's mean it's not not sinus rhythm, and also I can, so the heart rate, okay, so the heart rate is around 140 per minute, and also I can see that the cure is complex. They are not matching each other, like there are distance between each other. So I'm assuming the patient has atrial fibrillation. Yeah, there is. Yeah, I can't see any other thing. Okay. Okay, Jenny. So thank you very much for talking to me. And based on the history and okay, based on the history and examination, it seems like you have a condition called atrial fibrillation. Do you know what it is?
No, doctor.
Okay, so we have in our heart, we have 4 chambers. So 2 up is called atrium and 2 lower is called ventricle. So in a normal person, there is a place which we call is AC node, where that's make the electrical impulse, where our heart is getting pumped, and that's how the heart is pumping. So in your case, the upper chamber in lower chamber, they are not in a rhythm. So upper chamber is pumping and the lower chamber should relax, which is not doing so. Lower chamber, they are pumping on their own way. So there is some disorganization in the rhythm. So that's why you are not getting enough blood, especially to your brain. So you're not getting enough blood means you're not getting enough oxygen. That's why you're getting dizzy. That's why your heart is beating irregularly. You are feeling more palpitation. So it's not normal. So initial management, what we will do, we will so we will give you some medication. That medication will help you stabilize the heart rhythm. Okay, and also we will do some further investigation. So further investigation mean we will do full blood count. We will check the troponin. We will also check the lipid profile. We will also check the coagulation profile. And so once we have all these results, so then I will consult with the cardiology team, and from there we
Time
will
off.
go.
Thank you. Thank you, Dr. Abdul. You did really good. the history was good. Just few of the important differential diagnoses were missing, like thyrotoxicosis, important to rule out. Then definitely ask about some of the other DD like hypoglycemia, because if the patient skipped the meal today and then went for a walk, that's important to rule out. Pheochromocytoma can come as a palpitation, so ask those questions. And also, this is for middle-aged women. We need to make sure it's not a perimenopause as well. So ask the menopausal symptom a little bit. And very important that like tea, coffee, recreational drugs, these are also important, because the case that actually was in the exam, the feedback was like this: nothing was positive except patient was drinking 4 to 5 cups of coffee every day. So that's also very important. It doesn't seem like very important, but for exam purpose, sometimes that is the only thing that you can get. So ask those questions and definitely go through the palpitation cluster again. Look for some other DD like anemia, also one of the important differential to rule out. CNS, CVS causes will come here. So if you remember, we divide into CNS, CVS, then endocrine, electrolyte imbalance, medication. So all will come into your differential diagnosis in here. Okay. Other than that, in the ECG, always try to follow the format that we have shown you. So say that this is, I'm going to explain the ECG of John or someone like of Jenny, who is a 45-year-old woman presented with palpitation. Her heart rate is elevated, or if you can measure it, then say the exact number. Rhythm irregular. The P wave is absent and it has been replaced by fibrillatory wave. And then QRS complex looks normal. There is no ST changes. T wave seems to be normal as well. But the main thing is rhythm irregular in here. So it is most likely atrial fibrillation. Diagnosis, so you'll explain what is atrial fibrillation to the patient and what is the implication. So the implication, you need to explain that this can cause stroke. This can cause CCF. So that's important just to mention. Diagnosis, don't go for too much jargons, because it's a node, atrium, ventricle. Patient doesn't need to know anything like this. Just make it simple, because there are 4 tasks in here. You would not be able to like finish this case. So say that most likely from history and ECG, it looks like you might have a condition called atrial fibrillation. It is a condition in which your heart beats faster than normal, but the main cause is that it beats chaotically in an irregular rhythm. Because it is beating faster, your heart is not getting enough time to fill in. So sometimes along with the racing of the heart, you also don't get enough blood supply in your brain, so you feel giddy and dizzy. Okay, so just it. That's fine. You need to cut short when there is a 4 task like this. So you don't need to go through all of those upper lower chamber SNO, because it doesn't matter. As long as you say atrial fibrillation is a condition in which the heart beats faster than normal and it beats in a chaotic rhythm. That is the main gist of atrial fibrillation. When it beats chaotically like that, it can increase the risk of having a clot formation, and a small clot can dislodge from the heart and it can block the brain artery, causing a stroke. Because it makes your heart weaker, it can also lead to heart failure as a complication, which means your heart will not be able to pump enough blood to the body. Whenever you say something really risky to a patient, straight away reassure the patient. Please don't get scared, Jenny. It is not that you are going to get all of this. Right now, we know what you have got, and with appropriate management, we can prevent this complication. So right now, I'm going to admit you to the hospital. Always, as a junior doctor, your job is not to treat this patient by yourself. You have to involve your senior. So say that I'm going to involve my senior who is going to come and review you. In the meantime, I'm going to do some investigations. Also, a cardiologist will come and see you, and most likely he's going to give you a medication to reduce the heart rate. If that doesn't work, he might also try some medication to bring back this chaotic rhythm to normal. Also, when you have atrial fibrillation, as there is a risk of clot, we are going to assess if you have high risk of having a clot-related complication in the future. And if the score is high, you might also need to be on a blood thinner for the rest of the life to prevent any such complication. But this will be discussed in detail by your specialist. So you have to say all this line. These are all part of initial management. Okay, so management is not easy to finish, and there are 4 tasks in here. So make sure that you don't end up taking a lot of time in the history. So you have to know, you might just take, let's say, 4 minutes in the history, 1 minute in the ECG, 1 minute in your explanation of the condition, and 2 minutes for the management. If you can do that, you can finish this task. Okay. Thank you, Dr. Abdul. You did really good. It just a little bit improvement. That's it. But very good.
Thank you, doctor.
Thank you. Okay, who wants to do the last role play for tonight? Yeah, Dr. Jion, you can unmute yourself. Dr. Jion, I can't hear you.
One moment, please. Can you hear me now?
Yeah, this is fine now. Thank you.
All right.
Okay, so this is your case. Your 2-minute time just started.
All right.
All right, doctor, this is John. You can start.
All right. Hello, John. My name is Jiyoon Lee. I'm Dr. Jiyoon Lee. I'm here to help you today. So what brings you here today?
I'm just worried about getting this chest pain, and I just keep on getting them. So, because I'm 50 and my old man also had the same kind of chest pain and he died of it. So I'm just quite worried about it. So if you could find out what's causing this.
All right. First of all, I'm so sorry to hear that your brother passed away, and I'm glad you brought yourself here to figure out what's going on in your body. So let's do it together. So, about your pain, can you tell me more about it?
Yeah, it just like comes and goes, but most of the time it lasts for 1 or 2 hours. It's mostly in the middle of my chest, sometimes
Uh-huh.
also on the left side. So
All right.
yeah, I just don't know why it happens.
Okay. When was the last time you experienced this pain?
Just yesterday I had this.
All right. At that time, can you tell me what were you doing?
Nothing. I was just like just watching a TV.
Oh, I see. Did it disappear spontaneously?
Yeah,
Okay. And this happened since 6 months ago, right?
this has been happening over 6 months. Yeah.
All right, all right. Does this pain travel somewhere else in your body?
No, it's just it stays in the middle or sometimes on the left side.
Sometime middle or in the left side. All right. Um, about your chest pain, do you have any shortness of breath?
No,
All right. How about any aggravating factor or relieving factor? Do you feel it comes more often when you inhale breath?
no,
All right. How about do you have any other underlying disease?
not really. I'm
Oh,
fine.
not all right. Um, you said your brother died of heart disease. Other than your brother, is there any other family member who's with heart condition?
So it was not my brother, my father was there.
Oh, your father. All right. Oh, okay. I'm sorry. Um, so do you experiencing any weakness in your body or slowness in
No,
your speech?
no,
Okay, no. All right. All right. Um, the recent during that 6 months, did you had any flu or illness?
no,
Okay. Um, all right. How about your do you drink?
not really.
How about smoking?
Just 1 or 2 a day
And for how long?
for 20 years.
20 years. Are you on any medication?
No,
How about any recreational drugs?
no,
All right. May I ask what you do for a living?
just a banker.
You're a banker. Are you under a lot of stress?
No, doctor, I'm fine.
All right. Examiner, I'd like to see my patient's vitals, including heart rate, temperature, respiratory rate, and O2 saturation. All right, everything seems normal. Okay. Can you go back to the task list? Task investigation. Okay. I do like to see my patient's blood test result, including troponins, hemoglobin, lipid profiles, and ECG. All right. Okay. Should I explain this to examiner? All right. Can we go back to ECG again? Okay, dear examiner, I'd like to explain my patient's ECG who present to this clinic with chest pain. And according to ECG, the rhythm is regular, though there's ST elevation in 2-3 ABF, which indicates he's suffering from inferior infarct and myocardial infarction. And other than that, yes, I think that's all. And explain most likely like this. And John, thank you for waiting. And I'd like to explain your condition to you. So based on your history and physical examination and ECG, the most likely diagnosis you're having is inferior myocardial infarction. Do you know what it is?
No, doctor.
All right. First of all, myocardial infarction means your heart is not getting enough oxygen from your blood circulation. So some parts of it is not working accordingly. So that's why you're experiencing squeezing type of chest pain lately. And
Time up, doctor. Thank you. Very good. But the diagnosis is wrong.
oh, really? Oh.
Okay, let's talk about the ECG. So, what do you think the ECG has got, guys? Anyone? So, V1, there's a bit of T inversion, but not significant. V2 normal, V3 normal, V4 normal, V5, V6 normal. Maybe a bit of, no, not even a T inversion. Lead 1 normal, AVL normal, lead 2 normal, lead 3 has got a bit of T inversion, and AVF normal. So it is a normal ECG. Okay, so now remember one thing, sometimes it might look that it's a bit elevated, but it has to be at least more than 1 millimeter high. And at least it's not just one lead which will be elevated. So if it is inferior MI, lead 2, 3, AVF, all of them should be elevated. And the ST elevation will not look like a subtle. Okay? So it will be like definitely like when you see ST elevation, you know that it is ST elevation. It will not be just a tiny little elevation. Okay, so it can get confusing in the real life sometimes, but when it is ST elevation, you know it is ST elevation because it is not subtle. Okay, so this was a normal ECG. This patient had gastroesophageal reflux disease. If you ask questions, you will know it. So this patient having retrosternal chest pain sometimes goes to the left, doesn't matter, but most important clue was the pain doesn't have any relationship with exertion. It just happens whenever patient is even sitting on the chair or even like watching a TV. Angina, ischemic heart disease has a relationship with exertion. Without exertion, if a pain comes, it is not likely to be a case of heart condition. So that was the first clue. And then if you ask all the history of chest pain, like you first always ask, how does the pain feels like? I would give you, it feels like burning. Then you would get second clue that no, it is not a case of MI. Okay, so the format that we show you, there is a reason for it because you would forget it if you need to memorize everything. But with the format, when you remember format and you do that, even if you forget things, the format covers everything. So try to ask all those questions like Socrates' question, where exactly is the pain? Does the pain go to anywhere? How does the pain feel like? Anything makes it better or worse? Now, in this case, if you just say anything makes it worse, patient will not give you the finding that, yes, when I take a spicy food, it makes it worse. You have to ask directly. that anything makes it worse, like taking a deep breath or changing the position? No. How about taking any specific food, like hot, spicy food? Then patient will say yes. Then you get your diagnosis. That then you can always ask, do you get a bit of a heartburn-like feeling? Do you feel like your food is coming up into your throat? Does your mouth gets full with saliva? Does it get worse when you lie down or bend forward? So all of this will be positive in this case. Okay? Physical examination on the card was completely normal. The ECG was normal, so your diagnosis in here was just a gastroesophageal reflux disease. This was the exam case. So the exam can make you quite confused as well. So the main thing is that always trust your gut. Always try to understand that it is not that chest pain in a 50-year-old means that it has to be AMI. It can be anything else. So keep your mind open in the exam. That's the gist of this last case. And it happens a lot in the exam. The candidate usually feels that, no, we have done some role plays on this question, and you want the diagnosis to be that one. Like the case that I have done with a fall case with one of you, you were trying to understand that you were trying to diagnose this as a case of UTI causing recurrent fall, which is a case. So yes, a recurrent fall comes with UTI, comes with sinus bradycardia, it comes with a lot of other things. But if you think that you want a case to be that particular case that you have learned, that's the time you are in a trouble. So always keep your mind open, ask questions that feels appropriate and relevant. You will end up getting the answer. Okay, and if you get an answer, try to stick on that. Don't trust your gut that yes, I know that this is not MI. I know that this is maybe just a GORD. Then it is a GORD. Okay. All right, guys. That's all about cardiac role play today. I hope you learned things that is important for your exam. Now, we are actually at the end of our free 2-week session. There is another sessions tomorrow, which is basically about the new cluster, which is pediatrics. Definitely join that class, get some understanding about pediatrics. And after that, your 2 weeks free sessions will be over tomorrow, and our full course will be starting from 25th. Okay, so from Sunday you'll have a role play session with Dr. Samira, who is one of our other mentor for role play. Sorry, not Dr. Cynthia, and then you'll get another session on 28th and 27th. So there are back-to-back some of the classes coming up, but we will give you the schedule for the course student in the Facebook. Okay? Do you guys have any question? Any question about the course? You can unmute yourself and you can also ask if you like. So we'll just go through the course detail a little bit because many of you are not aware of it and you ask questions. But let's talk about it a little, right? So First Aid AMC clinical course is a very, very highly recommended course to pass your clinical exam. We have helped hundreds of students to pass the AMC clinical exam in their first attempt. A very few of our students needs to go for second attempt. That's where we excel. And it always comes with hard work that our students do and also the guidelines that we provide. If you follow those guidelines, you will pass this exam. So the course has started. We are doing the 2 weeks free sessions, which is a part of the course. If any of you missed that, you can always catch up with the missed class recordings, which has already been given in the portal. We took a trial class on 28th of July. The recordings is given in your Facebook group. The course will include full theory, role play on the theory-based cluster like how we have done today. We also have lots of role play cages in your portal starting from 2021, but we mainly focus on 2024 role play cages. You get 1 to 2 role play every week, including the 2 theory sessions every week. So sometimes 3 class, like definitely 3 class a week, but sometimes 4 class as well, which gives you a lot of time, a lot of way to do role plays if you are interested. You get last 3 years role play sessions, which is completely free. We don't ask for any excessive payment for our all these 160 videos at the moment that we have, and that covers all the role play classes that we have taken over the years, which is a like a very, very important collection. And if you can go through at least 1 year of them, you will be like knowing everything for this exam. Physical examination, because you will be going for exam in the next year, and next year there is a chance that face-to-face exam can start. So we are going to provide both online and face-to-face physical examination for your course. You get exclusive classes on communication and patient-oriented approach, online mini mock exams 4 to 6 weeks. You get recording of all the classes, and you get a 10 months of access to that recordings even after the course is finished. But the notes and other materials until you pass. We also have discussion on job hunting, APRA registration, campaigns, and others. There is a class coming up on 1st of September on career guideline. We will post it in the Facebook group about the detail of it, but that is one of the most important session for you. You can also get CPD hours we take 65 to 70. Now it will be more than 70 classes in 5 months, and you can definitely claim 150 hours by adding them if you're a member of RACGP or APRA. You get a course completion certificate. And again, if any of you are going for exam this year, you have got the placement, you don't have much time, we provide the just recently finished course recording in your portal. So if you want, you can finish the full course within even 1 to 2 months if that is really needed. The cost is $899 Australian dollar plus 10% GST and admin fee. The duration is 5 months, and all of our mentors are working in Australia currently. So all of them are well experienced. They're doing this for a long, long time. And as you know about myself, I have been like, at the moment it is not 5 years, it's 7 years experience. We have been helping the IMGs for a long, long time. We changed our way of approach based on AMC has changed. There's a lot has been changed over the last 7-10 years. And we try to update ourselves according to the new guidelines. We try to update according to what AMC wants from the candidates. So you get all the updated guidelines because all of us are working in Australia, and no one actually can give you the better guideline than us because we're practicing it at the moment. So definitely this is something I would say that there is a very few of you who would be able to bypass clinical exam, and most of you will need to go for clinical exam. So if you can continue like looking for a job, but in between that, try to finish AMC clinical exam if you can, because it just makes your life easy when you're doing the hospital work. Because it is hard to do the hospital, come to your home, like definitely take care of your family, and then prepare for a clinical exam. But if you have some time now, go for the exam, prepare yourself, and be done with it. Okay? All right, so if you want to enroll, the enrollment is open for another week. So you can contact me by Facebook Messenger, or you can contact us through this email, firstaidamc4536@outlook.com. Okay? So that's all about the course. I hope you are enjoying these sessions. If even after you are not joining the session, I hope you're learning some things which you can apply for your exam. and you can pass this exam. Will it take a while to get portal access? It takes, at the moment, it is taking at least a week to get the portal access because this is the admission time. A lot of queries come to us, so we try to give the access as soon as possible, but sometimes it can take at least a week. No exclusive recall sessions. It is a part of the course. And Dr. Delia, there is no confusion because we don't actually publish MCQ schedule on clinical Facebook group. There are separate Facebook group for MCQ and clinical. So if you see something on First Aid AMC MCQ, it is for MCQ. If you see something on the First Aid AMC clinical, that is definitely for clinical. Okay. Next class is tomorrow, Dr. Tamanna. So we'll be doing a pediatrics vomiting cluster tomorrow. Dr. Abdul, yes, this course includes everything. So it will include physical exam, medicine, pediatrics, gynae obs, psychiatry, which means everything. Okay. So there is nothing extra that you would actually need for this exam. And when you look for some of the feedback our past candidates has written in the Facebook group, you will always see that they mention that they don't need to go through any other materials except what we have given you. Not even a single book, except that you need to go through the AMC clinical handbook. Apart from that, there is nothing else you need. Okay? No worries, Dr. Afrin, you can always contact us. Either send me a message in the messenger or maybe send us an email. Okay? All good, everyone. Thank you. We'll see you tomorrow anyway. If you have any queries, feel free to ask. And the course, after the free 2 weeks session is over, the course next class will be Sunday. And we will provide the full schedule on the Facebook course group for the course students by tomorrow. Okay? Thanks all. Have a good night. Take care. Bye.